Hi everybody. My name is Marin, and with me today I have Brianne and Courtney, and we are going to present on Woude syndrome. So the outline of today's presentation is we're going to go over the genetics and the incidence and prevalence of this syndrome, and then we'll talk about the craniofacial and skeletal anomalies, along with any respiratory issues, muscular differences, and then go into the speech, language, and cognitive skills of these individuals, along with any hearing and dysphagia that they might have. And then lastly, we'll wrap up with treatment. So with genetics, the primary cause of Woude syndrome is a variation, or what we call a mutation, to the IRF6 gene. This specific gene is a protein coding gene with a transcription factor, which essentially means it binds certain areas of DNA, and it is involved in cells that affect the development of tissues of the head, face, skin, and genitals. In 5% of cases, the cause is actually a mutation or variation of the GRHL3 gene. This is also a protein coding gene with a transcription factor, but this one specifically helps to stimulate the movement of cardiovascular cells, also what we call endothelial cells. With Woude syndrome, it's an autosomal dominant. So this means that one part or one copy of the gene is affected, and it can be passed down by parents in most cases. So if you look at the picture on the screen, you see that the parent in pink has a copy of the mutation, and it is passed down to 2 of the 4 children. So with Woude syndrome, it actually has the highest genetic influence, and it has a 50% recurrence risk for each child that parent will have. So with this picture right here, of the 4 offspring, 2 of them, or 50%, have the gene mutation for Woude syndrome. The incidence of Woude syndrome is 1 in 35,000 to 1 in 100,000 people, and this is data that's taken out of Europe, Africa, and Asia. The prevalence is about 1 to 9 per 100,000 people. It's estimated that less than 50,000 people in the United States have this syndrome. So once again, Woude syndrome is the most common cause of cleft lip and palate based on a genetic influence. So this syndrome has a 50% recurrence risk compared to other syndromes that have maybe a 3 to 5% recurrence risk.
Woude syndrome is characterized by several craniofacial and skeletal anomalies. So this can include a cleft lip with or without cleft palate, and that can occur either bilaterally or unilaterally. Missing teeth or hypodontia is also present in Woude syndrome. According to a study by Heliovara, it was present in 65% of kids with Woude syndrome with cleft palate and 75% of kids with Woude syndrome with cleft lip and palate. And this is compared to only 33% of kids who only have cleft palate, or 58% of kids who have cleft lip and palate. The hallmark of Woude syndrome are bilateral lower lip pits, as you can see in this picture. So those 3 are the most common symptoms or craniofacial and skeletal anomalies of Woude syndrome. And then sometimes the other 5 on here can occur. So syndactyly of the hands, which are when the fingers do not separate appropriately. So fingers can look kind of webbed together. There can also be a slightly retruded maxilla. So this upper portion of the mouth, the bone, is slightly pushed in. It can also include a slight protrusion of the lower lip, so the lower lip would stick out, a smaller arch of the top of the mouth, or ankyloglossia, which is also known as a tongue tie when the lingual frenulum is short. Sometimes children with van der Woude syndrome can have respiratory issues such as heart disease or a heart murmur. The same study by Heliovara also found that kids with van der Woude syndrome may have a slightly constricted lower pharyngeal airway, but this did not seem to cause any respiratory issues. In addition to being connected to the salivary glands, the lip pits may also be connected to the orbicularis oris muscle, which is the muscle that is surrounding the lips, so it can extend into that lower one. This also did not seem to cause any muscular or any sort of movement difficulties. The only time that it did was when a surgical intervention disrupted that muscle.
Next, I'm going to talk about speech, language, and cognition in children with van der Woude syndrome. In speech, these children tend to have obligatory errors and compensatory errors. Obligatory errors are when the sounds are produced differently because of structural issues. So this could be due to a cleft palate that the child has, and the cleft palate must be corrected before we as speech language pathologists try to correct their sounds. Then compensatory errors are errors due to incorrect placements. And for this, intervention must begin early to help correct these sounds that these children have. Weak oral pressure consonants are also seen in these individuals. There's not enough air pressure built up, and part of the pressure that they do build up goes out through the nose. And these children can be hypo or hypernasal, and they also can have phoneme-specific nasal emission. So for language development, there may be a delay both expressively and receptively, so it's important that we also assess these children for their language development when we're seeing them for speech as well. And for cognition, there's a risk for learning disabilities and mild cognitive impairment. However, the IQ in these individuals are not significantly different from those without van der Woude syndrome. For hearing, these individuals are more prone to have middle ear infections because of the cleft palate and eustachian tube dysfunction. So the eustachian tube is responsible, there are muscles responsible for opening and closing the eustachian tube, and these muscles have trouble doing so, which leads to otitis media, a middle ear infection. There's also submucous cleft palate, and this has been shown to have a high frequency in middle ear disease and hearing loss, which does require surgical intervention to prevent infection and damage to the middle ear structures. For dysphagia, there are some feeding risks for these individuals, such as poor oral suction, low intake volume, excessive air intake, which could make them gassy, coughing and choking due to the poor coordination of the suck, swallow, breathe pattern that's needed to prevent aspiration, and nasal regurgitation. So when you are feeding an individual with van der Woude syndrome and cleft palate, we want to watch to see what's coming out of their nose. And there are some modifications when it comes to feeding individuals with cleft palate, such as on the picture on the slide, some bottles have a longer or flatter nipple that allow for compression instead of sucking, and others allow for parents to squeeze formula into the baby's mouth.
So we have already talked about the normal progression of cleft treatment in class a lot, so I'm just going to briefly go over this chart that we've already seen. Since children with van der Woude syndrome have a high incidence of cleft lip with or without palate or cleft palate, they will usually follow this kind of similar timeline as kids with just cleft lip or palate. So that can include things such as monitoring and seeing specialists for growth and development, speech and language, oral hygiene, surgery, orthodontics, audiology, and counseling, and that can start before birth and continue throughout the lifespan. Specifically for kids with van der Woude syndrome, this can include things such as feeding treatment, like Courtney already kind of discussed. So things like modifying bottles to make sure that the kids get adequate nutrition. Genetic counseling, since van der Woude syndrome is a genetic disorder, genetic counseling can start before birth, and then continue throughout or after birth to make sure that the parents are prepared. Surgery can include removing the lip pits, so that could include cutting them out and then sewing the lip back together, as this picture shows right here of an individual being prepared for surgery. And then also in the case of a tongue tie, it can include clipping that lingual frenulum to make speaking and eating easier. And then additionally, there's orthodontic treatment. So this can include things like exams before surgeries, especially before a bone graft surgery in case of a cleft palate. It can also include implants to help fill in those missing teeth. And then things like braces to correct the teeth once they are in there. And then also for the smaller arch, an expander to expand that collapsed arch.
Thank you for watching our presentation, and we have attached our references as well. So now that we've gone over our PowerPoint, we want to quickly share our handout that we've created that you can take with you as a resource to continue to learn about van der Woude syndrome, and then even share with future patients that may have this syndrome. So I'll quickly share that.
So this is our handout on van der Woude syndrome. It includes a lot of the main points we talked about in our presentation. As you can see, it starts off with genetics and the incidence and prevalence of this syndrome. Then we go on to craniofacial and skeletal anomalies, respiratory issues, muscular differences, and then we talk about speech, language, and cognitions in these children. And then on the other side of our handout, we have hearing dysphagia and treatment for these children. And in the middle part of this brochure, we have some resources that you can send to your families that have children with van der Woude syndrome. We have a website from Rare Diseases that talks a little bit more about their development and what this syndrome is. Then we have websites for these families to get in contact with craniofacial teams, both in Seattle and in Spokane, just depending on where you are located in the future and where these families are located as well. So we hope you found this presentation and this handout helpful. Thank you.